كريمة يعني هي more in line مع الثيمة بتاعت السيشن extensive coronary calcification hit it hard or it will hit you back. Well, case is a 70-year-old male patient. He is not diabetic or hypertensive and not known to be ischemic heart disease before. He was diagnosed with what is called mucosa-associated lymphoid tissue gastric non-Hodgkin lymphoma from 5 years. He received rituximab, targeted monoclonal antibody cancer chemotherapy, and he received 20 sessions of radiotherapy after that. And the patient was declared cancer-free after several checkups. He presented in February 22 with dyspnea, grade 3 to 4. His blood pressure was okay, and his heart rate was 97 beats per minute, and the ECG was non-specific. The echo showed picture of dilated cardiomyopathy with global LV hypokinesia, ejection fraction of 32%, severe mitral regurg, severe tricuspid regurg, and a PASP of 65 millimeter mercury. So the diagnosis was provisionally a cancer therapy-related cardiac dysfunction, although it is long-term after the termination of the cancer chemotherapy, but we know that some cancer chemotherapeutics produce irreversible cardiotoxicity. So the treatment was just full anti-failure measures with torzoretic, plerinone, carvedilol, valsartan, as well as procuralen. 3 months later, the symptoms improved, the ejection fraction improved to 45%, and 6 months after, even the ejection fraction improved further to 52%, and the patient became symptom-free on regular treatment. Unfortunately, 1 year later, the patient started to complain again of dyspnea grade 2 with exertional chest discomfort. The echo showed a declining ejection fraction again to 42%. And the multi-slice CT was requested to explore further the coronaries. The multi-slice CT showed actually a very high calcium score, approaching 3,700 total calcium score. The RCA alone was 2,500 Hounsfield units. بالضبط. Radiation has a very important role. So we performed a diagnostic coronary angiography showing a heavily calcific LAD and also some calcification apparent in the circumflex. This is the epicaudal view as well. This is the spider view, and the cranial view shows a long target of stenosis in the LAD with heavy calcification. And the RCA also showed a proximal heavy calcium chunk with significant stenosis. So the patient was subjected to a heart team discussion, and it was found to be of high surgical risk because of the prior medical history, of course, as well as the heavily calcified coronary targets. And the decision was taken to proceed with PCI after discussing with the patient and preparing our tools. The problem with calcium is the failure to cross the lesions, as well as the under-expansion that may happen if we proceed with stents without well preparation of the lesion. In a meta-analysis of 13 studies, it was found that calcified lesions are associated with 47% higher target lesion revascularization and 63% higher incidence of stent thrombosis. And of course, calcium detection can be done by angio, but more precisely by using intravascular imaging with IVUS and OCT. When we find angiographic calcium seen visually, we usually proceed with IVUS, and we try to score this calcium according to the IVUS, depending on 4 parameters. If the calcium has an arc of more than 270 degrees of more than 5 millimeter length, this takes a score of 1. 360 degrees arc of calcium takes also 1 point. The presence of calcified nodule takes 1 point, and when the vessel diameter is less than 3.5, this takes 1 point. Whenever we have a calcium score of 2 and more, this means that this patient needs calcium modification. The goals of therapy is first to attain crossability of the lesion and to modify the lesion by reducing the volume of calcium and fracturing it, وبالتالي optimizing the lumen gain. And this can be done by balloon-based strategy using scoring, cutting balloons, or ultra-high pressure balloons, or non-balloon-based strategies like rotational atherectomy, orbital atherectomy, intravascular lithotripsy, and laser atherectomy. How do we assess calcified lesions? We have 3 stops. First, before calcium modification, then after we do the calcium modification, and finally after stenting to optimize the stent implantation. But sometimes the lesions are uncrossable. We cannot even cross with the IVUS. So in this case, we have to start with rotablation as a starting maneuver to gain access for the other gears to go through, like the balloons, etc. So taking through the procedure, we tried to cross with the IVUS. This is the OptiCross IVUS catheter, but actually it could not cross the lesion. We expected this actually. And even when we tried to pull back the IVUS, it got stuck in the calcium, and you can see the deep engagement of the guiding catheter. So we tried, of course, we knew that we are going to proceed with rotablation, so we are going to switch now with the conventional wire to the rota wire. So we tried to switch over a microcatheter, but actually the Corsair could even not cross, and it gets impacted, and the same happened when we tried, it got stuck in calcium. When we tried to retrieve it back, also deep engagement happened to the catheter. So we pre-dilated with 1.5 Maverick balloon, which managed to cross the lesion, and then struggled again to advance the microcatheter, but could not cross as well. So what we did is that we impacted the microcatheter as far as it can get, and then we proceeded with a rota wire that managed to advance to the distal LAD. And then we started doing the rotablation runs with a 1.5 millimeter burr. Further runs of rotablation were performed until we managed to ablate the long target or long trajectory of calcification, the control angio to confirm that everything is well, and then this was the first IVUS run. Finally, we had to do an intravascular imaging. So the IVUS run showed that the distal lumen, reference lumen diameter was like 3.1, 3.25 millimeter. There are arcs of calcium everywhere. At this segment, the diameter of the vessel, the reference diameter was 4.4 millimeter. And further, there is also calcium arcs and 360 degrees of calcium with calcium nodules at different points. So after doing the rotablation runs, we started with a non-compliant balloon, a 3.0 balloon distally. We can see that there is much strain for the balloon to be optimized until it finally opened, and then a 3.5 millimeter NC balloon also in the proximal part. Still also, it was very difficult to crack these lesions, but finally we attained full balloon expansion. And then the control angio also to confirm that everything is okay. And then the second IVUS run to confirm that we have cracked the calcium adequately, and we can observe that the calcium was adequately cracked with different planes of plaque dissections. Then we started with the stenting, 3.5 24 drug-eluting stent distally, and then a 4.0 drug-eluting stent proximally. Without IVUS, we could not have attained these diameters because it actually gave us the correct sizing. Post-dilatation was done with a 4.5 millimeter non-compliant balloon. And finally, we did a control angio showing adequate results. We tried to do a post-stenting IVUS. This is the third stop, but actually the IVUS got malfunctioned with the stucking that happened every now and then with the calcium. Then we switched to the left circumflex. We pre-dilated with a 2.0 balloon We placed a 2.75 drug-eluting stent, control angio, and then post-dilatation with a 3.0 balloon, NC balloon, and this is our final result. So the key message, calcified coronary lesions increase the procedural complications and impacts long-term outcomes after PCI. IVUS is mandatory for quantifying calcium burden and to guide treatment. Always be ready with upfront tools for adequate lesion preparation and to ensure adequate stent expansion. Patients with prior chemo and radiotherapy should always be suspected for heavy calcium burden, and even in the absence of traditional risk factors as in our case. Thank you very much. This was the team that shared in the procedure. Shukran.